doing transtibial, better to switch over to that. It's a very little difference and quite much of gain.
I think first let us remove from our minds that a sedentary person requires suboptimal ACL reconstruction. Like, let's remove it. It's just an argument for doing average things. But now the transtibial has also improved its technique. There is a 2009 paper in JBJS, the anatomical reconstruction of the ACL by transtibial technique. So you can, actually your aim is to reach to that point. You can reach it through transtibial also by slight modification of the angles of the tibial tunnel. Or you do it by transportal technique, whatever you want to do. Please reach there. If you reach there, your results will be good. So it's not impossible to do. There are people in the world who are strong supporters of transtibial technique, and they are giving the anatomical ACL reconstruction through transtibial technique. It reaches there. It reaches there. Yeah. So the trick is, if you make your tibial tunnel a little short and more oblique, then you will reach there.
But sir, when we talk about anatomical ACL, it is anatomical in the femoral side as well as on the tibial side.
Yes. Yeah.
So, I mean, when we are going transtibial and modifying our tibial tunnel, how it can be anatomical on the tibial side?
No, you can't change the tibial footprint entry point. It has to be in the line of the posterior border of the anterior horn of the lateral meniscus, or if it is a fresh case, you can go between the anterior medial and posterior lateral bundle on the tibial side. So you put your guide there, tip of the guide, and then you rotate the entry point to make it short and oblique. And actually you have to go through the MPFL, medial collateral ligament. Not MPFL, medial collateral ligament.
Actually, you have to stay anatomical, so you have to have two independent tunnels. Going through the tibial tunnel will guide your femoral tunnel. So if you change to reach somehow to the anatomical point at the femoral side, you are shifting your tunnel, but the exit point remains the same, intra-articular exit point. So that's the thing. If you maintain that, tunnels are just for your support, just for your fixation. These are the just apertures where you are exiting. So you have to take care of that when we are talking about anatomical.
What you were talking about, going from the medial side, just anterior to the MCA. Problem with our patients is the tibia is very small. Once you go on the medial side, the bone coverage around the tunnel reduces. The chance of blowout are very high if you are using an interference system. That's the problem. Secondly, if your tunnel is not very wide, most of the time our tunnel is 2 to 9, not more than that. You don't get that much of play to reach to the anatomical point where you want to create your femoral tunnel. What I feel, I did that, I left it. Anteromedial portal is a very comfortable technique. People who have not done it, they feel discomfort in doing it. But there's hardly any change from your own original technique. But the advantage is you always have control to put your femoral tunnel at the bang on place where you want to go.
Is it good? Are you happy? Okay. So another trick what he is saying is, if you are using a offset guide, then you are going through the tibial tunnel and there is hardly any room for manipulation because the tibial tunnel is small. So the people who are strong proponents of transtibial, they are not using that offset guide. They are straightway with the freehand technique using the guide wire through the transtibial tunnel, and then you can manipulate the guide wire where you want to go. Okay, and then you hammer it with a little bit and then you drill it.
As soon as you put your reamer, everything is the same.
No,
you are widening
they are doing
These
it.
are the problems.
Actually, this technique was demonstrated by Dr. Basin from Delhi 2 days back here. So it is possible. So let's not say it is impossible. But I will further add that you should know the technique of transportal as well. In some case, if you think that you are not able to go, then you can shift to the transportal in that particular case. Routinely you may do trans-TPL. There are disadvantages of transportal also. So if you look at the literature, because the time is short, so we are not discussing those. So trans-TPL has its own advantages, transportal has its own advantages. So we close this session. No, Dr. Goyal is there. But in the program here. So you can have it in the next session. But here it is in the, that's okay. So we close this session. So thank you very much. Thank you speakers and thank you organizers.
Have been proposed for them. We all know them, that mechanical stability, when inadequate fixation, distraction, bone loss is there, they don't unite. Inadequate vascularity in cases of severe injuries, excessive soft tissue stripping or vascular injuries, or poor bone contact, which is due to soft tissue interposition, malposition, distraction. They all we know and we can take care of. Then there are various contributing factors which do not have a direct bearing, but we all know that they do have some effect, like infection, smoking, advanced age, venous stasis, burns, radiation, obesity, alcohol, and there are so many. In addition, now there are some other factors also. We all know that healing occurs in two ways. Either it may be indirect healing, where the fragments are moving, and here the secondary bone healing is taking place, which involves the bone marrow, periosteum, and soft tissues. On the other hand, there is a direct bone healing when we have a proper bone contact, and it is a direct cortical healing of two fracture ends, and this occurs primarily when it is a rigid fixation has been done. And here this cones form and they cross each other, and in that tip there are osteoclasts which resorb the bone, and the new bone is being laid down. So when the healing occurs, there are four components are there: cortex, periosteum, bone marrow, external soft tissues, and all of these are contributing to the healing of the fracture. And the extent to which each component is involved, it will depend on the conditions present in the injured tissue, what is the level of the growth factors, hormones, nutrients, acidity, oxygen tension, environment, and mechanical stability. So they all play a factor. So what are these intrinsic factors which we are talking of? One of them can be a genetic factor. There are some genes which have been known to predispose to impaired pathogen recognition and elimination, and they may lead to some defect in the healing. Then there are various cellular and molecular factors which are coming in now, and signaling molecules which are there are pro-inflammatory cytokines, transforming growth factor beta and other growth factors, and angiogenic factors. In pro-inflammatory cytokines, basically which we know are interleukin 1, interleukin 6, and tumor necrosis factor alpha. These are secreted by macrophages and inflammatory cells, and also the cells of mesenchymal origin in periosteum. The function of them, these cytokines, are the induction of downstream responses to injury by having chemoprotective effect, enhancing extracellular matrix synthesis, stimulating angiogenesis, and recurring endogenous fibrogenic cells to the injury site. These cytokines regulate the endochondral bone formation and remodeling. TNF-alpha here promotes the recruitment of mesenchymal stem cells, because stem cells are basic cells which are forming. The TNF-alpha promotes its recruitment and induces apoptosis of the hypertrophic chondrocytes. Absence of TNF-alpha results in delayed resorption of mineralized cartilage, and thus new bone formation is inhibited. And all of them, interleukin 1, 6, and TNF-alpha, show increased level of expression during fracture callus reshaping, that is at the time of fracture healing and remodeling. Coming to TGF-beta superfamily, they have got various factors like BMPs, TGF-beta, and growth differentiating factors. There are many more, 34 members have been identified. BMPs mainly 1 to 8 are involved in this process. Growth and differentiation factor 1, 5, 8, and 10, and transforming factor beta 1, 2, and 3. They are promoting various stages of intramembranous and endochondral ossification during the fracture healing. BMPs, we all know much about it since Master Jurist had advocated them. They are produced by osteoprogenitors, mesenchymal cells, osteoblasts, chondrocytes, and they induce a sequential cascade of events of chondro-osteogenesis, including chemotaxis, mesenchymal progenitor cell proliferation, and differentiation. Their regulatory effect depends on the type of targeted cells, differentiation of the cells, and local concentration. They also stimulate the synthesis and secretion of other factors like IGF and VEGF. And they stimulate the bone formation by angiogenesis also. There are so many BMPs known, and some of them are commercially available also, and they are being used in clinical situations also. They are acting in all these stages of chemotaxis, proliferation, morphogenesis, neoangiogenesis, calcification, and maturation of the bone. And it has been shown in various experimental conditions also, when their BMPs is given, the healing is much better. Then coming to TGF-beta. TGF-beta is a chemotaxis stimulator of mesenchymal stem cells, and this enhances the proliferation of mesenchymal stem cells, pre-osteoblasts, chondrocytes, and osteoblasts. It also induces the production of extracellular proteins as collagens, proteoglycans, osteopontin, osteonectin, and alkaline phosphatase, and also helps in the chondrogenesis and endochondral bone formation. Then there are some other factors like platelet-derived growth factor. Now these are released by platelets during the early phase of fracture healing, and this is also a chemotaxis stimulator for inflammatory cells, and they have been shown to increase the callus density. Another factor is fibroblastic growth factor, which are synthesized by monocytes, macrophages, mesenchymal cells, osteoblasts, and chondrocytes, and they promote growth and differentiation of a variety of cells like fibroblasts and osteoblasts. Then IGF, or insulin derived growth factor, is a very important growth factor, and this is coming from bone matrix, endothelial cells, and osteoblasts and chondrocytes, and they also helps in this bone union. Then coming to angiogenic factor. These are the factors which produce angiogenesis, and this is a new vessels which form, which are leading us to bone formation. And there are two separate pathways, which is a vasculoendothelial growth factor dependent pathway and angiopoietin dependent pathway here. So optimum bone regeneration requires adequate blood flow, and during final stages of endochondral ossification, remodeling phase, specific proteinases, this does happen. And there are essential mediators of neoangiogenesis and endothelial cell mitogens. Angiopoietin 1 and 2 are regulatory vascular morphogenetic molecules which are related to the formation of larger blood vessels and development of collateral branches from existing vessels. So they help in vascular formation. And it has been seen that fracture repair is enhanced by exogenous administration of VEGF. It was published by Street et al. And we have done some work on an arginine and other nitric oxide donor which proved angiogenesis. They have also helped in fracture healing. Sorry, this. The angiogenic factors such as VEGF, BEG, there's various factors of angiogenesis are there, and they are produced by osteoclasts and osteoblasts, and they regulate endothelial cell activities here. So all these factors are working here which help in neoangiogenesis there. In addition, there are various systemic factors which are working towards bone healing, like parathyroid hormone, thyroid hormone, and we all know the effect the parathyroid can cause osteoporosis also, and once we give a parathyroid, then it heals. So in the same way, now it has been shown that parathyroid probably may be useful in these type of fractures which are recalcitrant, which are not healing properly. Then growth hormones, vitamin D, and sex steroids are also factors, though their actual role is not proven, but they have a factor in bone healing. Cellular factors for cells, among cells main is stem cells, and it has been seen that during fracture healing their stem cells have a role, and they are produced by bone marrows, granulation tissue, deep layer of periosteum, endosteum, and surrounding soft tissues also. Perivascular mesenchymal stem cells that exist in blood vessels wall, they also contribute to fracture healing. So all the cells from any of these bone marrow and other places can be, stem cells can be made active, and they can help in fracture healing. So when we can summarize all these signaling molecules or endogenous factors, there are cytokines and TNF-alpha, they help in the inflammation, enzyme growth and differentiation, BMPs, TGF-beta, and they are working. Angiogenesis, fibroblastic growth factor, VEG, and BMPs are working, and these are some inhibitory factors which may inhibit bone healing if they are present. So if we go back to the fracture healing process, there is the first stage where the inflammation is there, then there is soft callus formation, hard callus, and remodeling does occur. In hematoma phase or inflammation phase, it is the PDGF, fibronectin, TGF beta interleukins, they have a role, and they trigger the influx of inflammatory cells. Coming in the fracture hematoma stage, the VGF and interleukin 6, they have a role, and they affect, if we facilitate them therapeutically, then it may be, and fracture healing might be enhanced. In soft callus formation stage, there is a connective tissue there, and there is angiogenesis is required. So those factors which produce angiogenesis may be useful. And the fracture healing requires blood supply, so here VEGF and angiopoietin dependent pathway will be helpful. In remodeling phase, it is a type 9 collagen and type 2 collagen, which they have a role, and osteopectin also. So these all factors will be helpful in fracture healing. And it is the timing of cellular events. Day 1, these are the endogenous factors. At day 3, TGF beta and BMPs. At day 7, TGF beta and growth factors. Day 14, TGF beta growth factors, and these VEGF will be there. And at 21, again a remodeling phase, also TGF beta 1 and 3, and growth factors and BMPs also have a role. So understanding of these factors will help us in predicting the fracture healing, and if a person is having deficient in this, then it might help delay the fracture healing. The actual understanding of all these factors is still in the experimental stage, but maybe in future with the proper understanding of these factors and therapeutic use of these factors, that fracture healing might be enhanced. Thank you.
Would you like to come over here, Professor Goel? Are there any questions from the audience? I know it's too much physiology, and for average person like me, it's very difficult to understand. But I think, there is sort of wind in the market that, you give arginine, the fracture heals quicker, and you give this herbal product, the fracture heals quicker. And, a lot of people have been working on this plant Caesar for quite some time, and few companies have come up. So I would like your opinion, Professor Goel. If you have any experience with these exogenous products, some of them may be endogenous, like arginine.
As at the moment the science is, they are only experimental. The only thing work is going on all these type of things. Actually what will be helping on the site is still not well known. That's the thing.
Right.
But these factors are playing a part, and we have to do further research and find out which factor, if given from outside, will help, and what way we can enhance them.
I think still there is a lot to be understood. So we have to stick to basic features like reduction, immobilization, whether external or internal, and of course, natural healing. There is no magic booty which you give to the patient and the fracture heals. So we have to wait for that day. Any other question, please? Thank you, sir. Thank you very much for your very elaborate talk, and I wish you continue researching like this and enlighten our knowledge. Thank you, sir. Now, our next speaker is Dr. Ashok Johari. He is speaking on fibrous dysplasia, which is a very notorious condition. It can occur in any bone, maybe due to genetic mutation, but which gene is involved, we don't know. And so far, we have only known the surgical treatment. And now, there are a lot of people who are using some chemical therapy or chemotherapies. Let us see what Dr. Johari has to tell us. Dr. Johari, please.
Okay. Thank you, sir. Good afternoon, everyone. I'm going to speak on an enigmatic problem in orthopedics. Fibrous dysplasia still remains an enigma. Let me introduce the subject by saying that fibrous dysplasia is a failure, and you have a failure of many processes here. You have failure of remodeling of primitive bone to mature lamellar bone, which is very, very essential for the bone strength. There is failure of bone to realign in response to mechanical stress.
So there is a problem, even if the bone is okay, there is a problem of realigning, because as we know, stress causes realigning and trabecular formation, and these trabeculae which are formed are best aligned to resist the forces which are put on the bone. So there is a failure of bone to realign. There is a failure of maturation, which leaves a mass of immature isolated trabeculae enmeshed in dysplastic fibrous tissue. The bone does not mature, and because of all these problems also, there is a problem with mineralization, and the immature matrix does not mineralize normally. So on all four counts, this is a failure, and you can imagine that this bone has pathology. This pathology is going to weaken it immensely and create a lot of problems for the orthopedic surgeons to solve. The incidence is equal among males and females. Monostotic fibrous dysplasia is more common than polyostotic variant. Monostotic to the extent of 70 to 80% and polyostotic 20 to 30%. Because polyostotic is the more, let's say, aggressive form, or malignant form. Really it's not malignant, but what I intend to say is it's more aggressive. It is discovered at a much younger age, the mean age being 8 years, In most series, that is the mean age of discovery. The clinical features we are all very familiar with. I'll just run through. Lot of these can be discovered incidentally, so they are asymptomatic, especially the monostotic forms. There could be a small lesion somewhere which is diagnosed as a fibrous dysplasia and which doesn't cause any problems. Bone pain, especially when the lesion is around the neck of the femur, these are prone to cause bone pain. Deformity is well known in especially the polyostotic variant, the shepherd's crook deformity or extreme varus of the hip. Patients can have pain which is unexplained, but which is because of fatigue fractures, because the bone is weak and the bone fractures on stress. So there is fatigue fracture, and there are pathological fractures when the stresses are higher, and you have presence of cafe au lait spots in 30% to 50% of the polyostotic patients. Especially this happens with the Albright syndrome. The forms of presentation, so you have these four forms. Monostotic is a single bone involvement. Nothing else is present here. Polyostotic, you can have multiple involvement, but the McCune-Albright disease or Albright syndrome as is known is multiple bone involvement, usually one-sided, associated with cafe au lait spots or coast of main type of pigmentation in the body, brownish pigmentation, which is irregular, and there can be endocrine disorders like hypoparathyroidism, hyperthyroidism, etc. There is another variant which is called as Mazabrod disease, which is multiple bone involvement along with soft tissue intramuscular masses, and these are usually myxomas. So this is the Mazabrod's variant. So polyostotic disease is monomelic or polymelic. The affected bones generally, craniofacial, clavicle could be involved, the femur, tibia, pelvis and bones of the foot. The tibia is usually found bowed and in conjunction with a thin bone that has a ground glass appearance on X-rays. There is cranial bossing, prominent jaw, so you could have problems of enlargement of the jaw and a cosmetic disfigurement. There is facial distortion. So these are examples of polyostotic involvement, and you can see that the bone is involved markedly. Throughout the length, the bone is involved, extensive involvement, and pathological fractures are not uncommon in this variant. So the associated syndrome, McCune-Albright syndrome, is polyostotic fibrous dysplasia, cafe au lait spots, and endocrinopathy. Mazabrod syndrome I already mentioned, polyostotic fibrous dysplasia and soft tissue myxomas. The endocrinopathies which can be associated are hyperthyroidism, hyperparathyroidism, diabetes mellitus, hypophosphatemia, acromegaly, hyperprolactemia, and Cushing syndrome. As a corollary to this, if you have a patient with multiple bone involvement, fibrous dysplasia, and who has pigmentation, we need to investigate that patient for presence of endocrinopathies, and he needs to be seen by an endocrine specialist. So these are examples of monostotic fibrous dysplasia, the lytic variant, markedly radiolucent. The next one is a patchy involvement, so that you have areas of opacity combined with areas of lucency, and this is more or less a healing variant, sclerotic, where there is a sclerotic rim which actually contains the lesion of the dysplasia. Polyostotic involvement, ground glass appearance, and shepherd's crook deformity. The last on the right is a classic example of a shepherd's crook deformity. The investigation besides the plain X-rays, what we do is sometimes a CT scan to show you the complete involvement, and also it's homogeneously ground glass on the CT appearance. Bone scanning, when you suspect polyostotic involvement, you do a bone scanning and the uptake is picked up, the technetium is picked up in different areas, and that can tell you that it's the polyostotic disease, and then you can go in for localizing investigations. Then MRI marks the soft tissue components very well, and especially in transformation into malignant varieties, MRI may be very, very useful. Some cases histopathology is required to differentiate the problems. You can make a differential problem with maybe a Ewing sarcoma or an osteosarcoma. This can be a real problem, and sometimes you would need to resort to histopathology if the clinical behavior is suspicious. So natural history is very, very important for us to know, especially in a polyostotic involvement or the McCune-Albright syndrome. What we find is that it is a progressive disease if untreated, and this you see within 5 years from D to F, the neck shaft angle has reduced and the person has gone into a marked Coxa-Vara and a Shepherd-Crook deformity. So this is a natural history, which means that at this stage we need to do prophylaxis and we need to prevent this from happening. So for example here, even tibia, you see the way the tibia gets bowed in spite of internal fixation. As the child grows, there are unsupported areas and the tibia can get bowed and angulated. Now coming to the management, which is the crux of this problem. Well, depending on what are the clinical problems, we offer management. Asymptomatic and incidental lesions only, clinical observation is advised. Follow-up radiographs every 6 months to verify that there has been no progression, especially if the area is a critical area. Then you follow up and see that it is not increasing in size. In newly identified cases, a bone scan is needed to exclude a diagnosis of polyostotic dysplasia, and when polyostotic disease is found, refer to an endocrinologist for endocrine and metabolic testing. This is very, very important. Now, despite the absence of histologic evidence of abnormal osteoclastic activity, there is really no osteoclastic activity, it is an inert area, but people have used bisphosphonate therapy, and there are papers which attest to the efficacy of bisphosphonate therapy. It helps to improve function, decrease pain, increase bone density, and lower fracture risk in appropriately selected patients with fibrous dysplasia. So it can be used along with surgery, it can be used before surgery or even after surgery to help alleviate the problems, main problem being pain and repeated fracturing. What has been used in the literature is alendronate, pamidronate and etidronate. Alendronate you can use daily, 10 milligrams per day, or 70 milligram weekly, 70-75 milligram weekly dose. Pamidronate is used as an injection, 180 milligram total dose, that is 1 milligram per kilogram body weight, given slowly as an infusion over 4 hours, and this is given in usually 3 divided doses, which are repeated at 6-month intervals. These are the 2 commonly used drugs. Etidronate can be used oral or intravenous, and the dosage is weight based. Surgery is indicated for 4 reasons. Confirmatory biopsy, sometimes as I mentioned, especially if your differential is a malignancy, you need to do a biopsy. For correction of deformities, for preventing pathologic fractures, and for eradication of symptomatic lesions. Patient's age is important because monostotic lesions remain active in the younger age group. Towards skeletal maturity, they actually stabilize, and the need for surgery diminishes as the patient ages in a monostotic lesion. Polyostotic lesions still keep on progressing, and they can give rise to fractures, pathological fractures even later, Shepherd-Crook deformity, pathological fractures, so that they need more aggressive treatment. An example of a patient here with a history of multiple fractures since the age of 5, treated conservatively, all these fractures were treated conservatively, referred at the age of 19 years with a loss of walking ability, and he required a lot of support to walk. People used to actually hold him and carry him around. And history of pain in the hips. He showed a short stature, bowing of both lower limbs, tibia and femur. Hip abduction was absent, rotations were diminished. Bilateral Shepherd-Crook deformity and bilateral Coxa-Vara. So in spite of our best efforts, these are the best X-rays we could obtain because of the marked osteoporosis which was present. You see the Shepherd-Crook deformity. Both the sides have a Coxa-Vara. The left has a marked Shepherd-Crook deformity. This is in a 19-year-old boy, and you can possibly appreciate the shepherd crook here. There is angulation here, marked angulation, and this is the head neck. So even here there is a significant varus. So this may be about 40 or 45 degree from the shaft. What do you do in this situation? In 1999, I did a valgus osteotomy and fixation with the DHS for the right femur. A couple of months later, we did it for the left hip, and then we proceeded to do his left tibia, correction of procurvatum and valgus, and fixation with K-wires, that stage. So this is his hip in 2007, a couple of years after. You see the extensive involvement, it's bilateral. The pelvis is involved, this is involved, this whole area is involved. You know, he did reasonably well, and subsequently, he's become totally independent in his ADLs, can walk around, and is married and has children now. So this can help. Internal fixation can be a real help in fibrous dysplasia for prophylaxis as well as for correction of deformities, making them more useful and productive, you know, and being able to take load on their own legs. For deformity correction, as I mentioned, postpone treatment until skeletal maturity because of the risk of recurrence with subsequent growth. The osteotomy sites healed with dysplastic bone, and this bone itself, whatever new regenerate is there, is prone to fractures because of the nature of that bone. So it can create a severe deformity. So try and avoid deformity correction, but if there is an impending fracture, you need to really think in terms of prophylaxis. The poor physical qualities of dysplastic bone make conventional internal fixation devices less effective. Intramedullary fixation is the fixation of choice, extending into uninvolved bone, and that's the most effective way of maintaining your correction and preventing recurrence of deformity. An example here of the problems which can be inherent in this: child having a progressive deformity, extensive involvement. Unfortunately, the X-ray is not good. It's very extensive involvement, and she had a nailing. In order to have some sort of a prophylaxis, had an infection. Part of the bone, actually, that area, a window had to be made to curate out, settle down. Subsequently, you see, after a couple of years, the varus has gone on increasing. Okay, this area is weak, even the pelvis is involved, and the varus goes on increasing. What do we do at this stage? Well, this can be corrected. This was corrected, but the implant totally rotated. The whole thing actually just cut out of bone, you know. And this was the situation. In spite of additional fixation, this is what happened to her a year later. So she had an orthofix treatment, which not really a very good treatment, but she had problems of varus, she had shortening which was marked, and we thought we may be able to correct all these problems. So May 2007, she had this neck shaft restoration and lengthening from a lower site, or from the same site, I think. She had a lengthening, but again there were problems here, because as we tried to distract, what happened was the shank screws actually tried to cut out and come out of the bone, you know. So this was the problem we were left with. So we abandoned the thought of distraction. So distraction was carried out to some degree and then abandoned because of the soft bone. And she was left with this sort of a picture in 2008. This is 2009. Extensive involvement, and we again did it in 2012. She was better. The neck shaft angle had been restored to some degree. She was better, her bones were stronger, and we did this. We lengthened her by about 7 centimeters eventually, and then had a implant fixator removal and plate, you know. So hopefully that's a happy ending for her. She's in the US. We'll follow up in the next month, actually. So sometimes you have problems of recurrent lesions, extensive lesions which have been operated, curated, grafted, you know, and curettage grafting doesn't have much role in these cases because they tend to recur. So recurrence rates are very, very high with fibrous dysplasia, and this patient, I think a 7-year-old patient, had this problem going right up to the growth plate, nearly to the growth plate. So we excised that lesion. This was about 20 years back. This was done maybe in 94. This was excised, and we did a reverse transportation on a Elizaro frame. So the transportation is starting from here, and this fragment was brought up. So this fragment has been brought up to meet with the original parent bone, and this is after healing. You see the sort of reformation. However, one can't be sure that there are areas of involvement here. This is a picture 3 years after this surgery. Now, as far as bone grafting is concerned, try not to use cancellous bone grafts for fibrous dysplasia because invariably they get absorbed, and what is recommended in the literature is to use cortical bone graft. Cancellous bone graft or a autogenous grafts really does not do very well. Cancellous autografts don't do very well because they just tend to get absorbed. And as I mentioned earlier, simple curettage and non-structural cancellous bone grafting in active lesions are not likely to correct deformity or relieve symptoms, So cortical allografts are possibly the best for this sort of a situation. Sometimes you may have to resort to microsurgery for extensive involvement. So this child actually went on having a progressive lesion, very extensive. It comes from the upper fourth of the humerus way down. So we thought we would resect it. So that area was resected and then reconstructed by using microvascular graft, bone graft from the fibula. The anastomosis has been made by branches of the profunda brachiae artery. In fact, that anastomosis is shown there. This is the area of the anastomosis. So this was put in and a tracer study showed that this was working very well. This was live and you can see the bone uptake in the grafted area. So this was the situation. In about 2 months, 1.5 or 2 months, he healed up very well and the fixator was removed. You can see this bone reconstituted very well and he had very good functional results. So sometimes this is useful. I would like to end, I think we can give lots of examples of problems with fibrous dysplasia, but something which everyone should know, that this is a very broad diagnosis and patients behave differently depending on whether they are monostotic or polyostotic. Differentiate between the two. Polyostotic, you have to be really cautious. Monostotic with thinning of the cortices, especially neck involvement, neck of the femur, you have to be very, very cautious. Any patient with fibrous dysplasia needs a thorough assessment and investigations. In polyostotic fibrous dysplasia or McCune-Albright syndrome, the natural history may be progressive, is generally progressive. I should actually put it as generally progressive. Prophylactic surgery may be required for deformity, prevent pathological fractures and restore the mechanical alignment. So I think these are important points. As far as grafting is concerned, I think I already told you that try to use cortical allografts or cortical autografts, but not cancellous one, because the cancellous just disappears. And this has been so in our own experience. We have tried bone substitutes, we have tried BMP, we have tried cancellous bone, but it all just disappears, So internal fixation and if at all supplementation, it has to be by cortical autografts or allografts. So thank you very much for your attention.
Thank you, Dr. Johari. This was a good talk on a very difficult subject. Please be seated and let us see. Are there questions for Dr. Johari from the audience?
He has a very big series on this work of Harris and he has also said that cortic grafts are better than the cancellous.
In the literature, there are about 3 or 4 papers which it has.
With so much of deformity, I think you have to assign a segment of bone also. In spite of the fact that you are again going to give a start. But if right in the beginning you are able to give a right good neck shaft angle, probably the incident will be.
That's true, but one of the problems even after giving the neck shaft angle and getting a good neck shaft angle is the cutout of the implant. I think you have to start supplemental pharmacotherapy along with it. That is one area we were not stressing, but I think allantoin possibly is very important.
I think now it's in the literature that we should give that.
I think that's really important. And structural support by whatever means it can. Cortical allografts.
So have you come across congenital, pseudarthrosis of the tibia picture in fibrous dysplasia?
Well, actually initially we did a lot of histopathology from the material which we got out, and very difficult to make out, because people reported that as fibrous tissue, But whether it is fibrous dysplasia is really very difficult to say. We could never find any neural element in it, especially even in cases of neurofibromatosis. But fibrous tissue, yes, but that does not necessarily make it a fibrous dysplasia.
Yes.
It was never reported as a fibrous dysplasia.
Right.
So there is a difference between the fibrous tissue and fibrous dysplasia histopathology.
Yes.
Fibrous dysplasia has these thin strands of bone which are not surrounded by osteoblasts. They are like inactive. There are osteocytes on it and there are strands or small trabecular bone surrounded by a marked amount of fibrous tissue. And fibrous tissue is pure fibrous tissue. There are no bony strands. These are two different entities.
Right.
So I have not really come across it.
So I have treated 2 of them in.
I know, but it's difficult to prove.
Yeah, the other features in the, yes, I agree with you. It would be hard to prove, but other features were present. And of a series of more than 51, most were neurofibromatosis because you see the other features. in most of them. And these were clearly the bones showed characteristic features. Thank
Yeah,
you.
there's only one other area you need to differentiate in what is called as osteofibrous dysplasia, which is something of a different entity. It is not fibrous dysplasia, but it resembles fibrous dysplasia and involves the tibia only, predominantly the tibia. The adult form of it is an adamantinoma, but the younger form is a osteofibrous dysplasia, and it is not ground glass, unlike fibrous dysplasia. It is like a septate variety, which gives rise to curvature of bone, deformity, and pathological fractures, and which has difficulty in my hands to get them healed has been quite difficult. But this is another entity we need to keep in mind. Osteofibrous dysplasia. It's not central. It's very eccentric, goes peripheral, and it's not homogeneously ground glass. There are like septate in it. But extensive involvement of bone.
Thank
From
you.
the
Yes,
middle
sir.
third to the lower third tibia.
Yes, sir.
So. Yeah, we mentioned that, asymptomatic lesions, incidentally discovered lesions, conservative. But where the natural history has been shown by repeated papers to be progressive, I think we should not really be thinking in terms of conservative treatment. Yeah. No, the first thing we mentioned was conservative treatment. Yeah, monostatic fibrous, I did mention that, sir. Monostatic fibrous dysplasias, leave them alone unless they are creating a structural problem. If it's a small lesion, it's asymptomatic, just leave them, and they are likely to disappear as the child becomes skeletally mature. You just leave them alone.
Yes, sir.
Lesion, progressive lesion, should we go for excision or grafting supports?
Yeah, I think, see, basically it's a benign lesion. There is no doubt that it is a benign lesion, but structural support is important. Structural support. So just curettage and bone grafting in itself may not be enough, because that is a vacuum, really. So you need to provide structural implant support, to that, and then you could even go for a cortical bone graft.
In short, in few cases, excision,
Yeah,
complete excision.
yeah. Because of recurrence. We excised when they were recurrent lesions.
We need not to excise.
Yeah, maybe if it is an extensive lesion,
It should be excised.
if it is extensive and unlikely that your curettage can reach all the places, so it is extensive, very extensive with cortical involvement, I think it will be better off to be excised, But if it is a well localized thing, well, you have other choices, But extensive involvement with the cortices involved, I would definitely excise and reconstruct if there is a possibility to do that.
Also, the recurrence is less, if you exercise the segment. You said, do you always use vascularide fibular graft?
I never said that, sir. This
Yes,
was exceptional case. Sometimes
I
with
see,
extensive
I see.
involvement, you could do that, I was just shown as a possibility.
Yeah. Because I have experience of using free fibular graft up to 14 centimeters
Yeah, you could.
with
you could.
measurement.
You
And
could.
you also use some cancellous chips at the ends.
Yeah, at the ends.
And you have to immobilize with a plate.
Sure,
With
sir.
a plate also.
Sure.
And that works very well.
So this case, as you will remember, we just did an external fixation. We put screws at the ends and some cancellous chips, mainly the micrograph, microfibula, and you see that immediately the technetium scan is updated. That was done the next day, So it remains as a live graph, which is healing very, very fast. So 1.5 months we could actually remove the fixator and get him to
You
his
have
normal activity.
any experience of using zoledronic acid?
I
Because
have
much more convenient.
no personal experience with that.
But it is mentioned that can be
Yes,
used.
Rizidronate can be used.
Yes, okay, thank you very much.
Thank you, sir.
Thank you. Now the third lecture is on, sorry? Did you say something? We have another lecture on scaphoid non-union. Scaphoid non-union, that's another notorious bone. Is Dr. Saurabh Agarwal here? Dr. Saurabh Agarwal? No? Well, then we have our speaker from abroad, a retrospective study of the surgical repair of contaminated open Achilles tendon injuries from Bhutan. Dr. Sonam Dorji?
Thank you. I'm Mr. Friedman from England. I wrote the paper with him, and I'm going to present
Oh,
the
I
paper
see.
for him. If that
Welcome,
is
sir.
all right.
Welcome, sir.
Thank you. So, thank you very much for inviting me. I've recently spent a month working in Bhutan, which, as you probably know, is a small country to the north of India, and until the 1950s it was cut off by virtue of its geography. They've only been doing orthopedic surgery for the last 20 years by slipping in an Indian-style squat toilet. They haven't particularly changed over the years, so between the last 5 years they've seen 40 cases, a variety of occupations, and it happens because they're squatting in the toilet and they slip. Most of these bathrooms are poorly lighted and they're poorly maintained. And unlike closed ruptures, which these have a wider range of age groups, and males and females are equally infective. So the management protocol, first of all, it's quite unusual to get acute tendon divisions where they're often occurred in an infected area. And their treatment there is emergency debridement and primary repair with antibiotics and very thorough attention to wound debridement. The problem is quite a lot of the patients turn up late because it takes a day to get to the hospital, and the decision then has to be made whether to debride them and give them antibiotics or repair them early. Their post-operative course was the same as for closed ruptures, which is an equinus position for 6 weeks. And they would make a wound in the plaster. Not a wound, I mean a window. So, rather surprisingly, they had very few complications. And I say surprisingly because mostly these were infected cases. They had 2 which they picked up. I'm talking about deep infections as opposed to perhaps superficial skin infections. This is not uncommon. It's a relatively complex laceration and they're often deep. But at 3 weeks they're healing well. We've put them up to a neutral position. It's another case, and you can't perhaps see this from here, but it is relatively close to the posterior tibial vessels, and whilst I was there, one of the patients came in with division of both the artery and the nerve. So exposed them operatively, and some of them are incomplete, some of them were complete. And after repair, we went for primary wound closure. Here's another case just showing there the proximity of the neurovascular bundle to the Achilles tendon. And then that's the surgical repairs complete, and then into a plaster cast. This was a rather more difficult case. They presented 4 days after the injury. They've already got skin retraction and loss of skin coverage, and the wound will be infected. But after debridement and closing what tissues we could, the rest was left to granulate, and then they had a later rotational flap. There were some cases of re-rupture. These are particularly difficult because often the tissue quality is very poor and there's shortening of the Achilles tendon. But most of them did come together and then they were reoperated on and put into an equinus cast. Some of them were bilateral, but most of them got a very good result. So the conclusion is, I bring to you, this is, in that country at least, a very common injury, at least 1 a week, of a division of the tender Achilles, despite the fact that it occurred in a toilet setting. Early surgery is the message, as most of them do very well. Thank you very much.
Thank you, sir. Questions from the audience, please? In this country also, the situation is not much different. Especially in peripheries, you see a lot of these wounds and they present late. And mostly the wounds are infected, What we do a debrimo, and then in the second setting we do a repair or graft. So I think, this is the problem in developing countries, that we do get situation like this. Any questions?
Although, as you said, it's quite common. In fact, there's only one other paper that's been published. That was from India on 18 cases. Otherwise, the world literature search, they've not been reported, surprisingly.
Yeah, I quite agree, because most of the publications are from teaching hospitals.
Yeah.
In fact, India has a large number of private practitioners who are too busy to treat cases rather than write papers. If they have a OPD of 100 cases and operating 7 or 8 cases a day, I think it's sometimes become difficult. Thank you, sir. Thank you very much.
Thank you.
Thank you. So that is the end of session. Uh,
Well, good afternoon, everybody. I'm Dr. Shah Alam from Delhi, and I'm here for the pediatric session. Unfortunately, a bit of change in the pediatric session, but we are going to go with the talks. Some of our speakers have not yet reached, some issues of traffic and all. So, instead of the free time that we have, we can start the session right now if you all are okay with it. Is that all right? Yeah. So, just let our chairpersons come, and I'll start with you. Can they use your own laptop? No. No? You have to give it to him.
Chairpersons and friends, I was told that Matthew Varghese will cover varus osteotomy in detail, so I should talk on valgus intertrochanteric osteotomy. The child with hip disorder may present with hip or knee pain, you all know it. Or he may have shortening or a limp. Or it may be difficult for him to squat on toes or sit cross-leg position. Now these are the various conditions wherein you can do a valgus intertrochanteric osteotomy like coxa vara, femoroacetabular impingement, hip dysplasias, fibrous dysplasia with patellar fracture, neglected traumatic disorders and post, and excessive anteversion which you find here. Again we can do a valgus osteotomy with derotation procedure. Slip epiphysis capitis femora. Now here after pinning 10 years you find again varus and cam-like lesion. So again I think a valgus osteotomy is a better choice. Congenital coxa vara. Again you can place the pseudarthrosis at right angle to resultant of body weight forces and this heals. Pathologic fracture secondary to fibrous dysplasia or simple bone cyst, they heal very well with no recurrence. Shefford cruciformity, you just listen to Dr. Ashok. Multiple procedure you have to do. Sequelae of healed septic hip or tubercular, coxa brava, elevated trochanter, limited flexion, no abduction. Again, osteotomy combined with lateralization and distalization of trochanter which you find here. That is a good answer. Neglected fracture neck of femur with neck is absorbed, Sandhu's type 3. Avian changes with no collapse. Again, osteotomy is a good answer. A specially designed chisel for the children and plate holder. You have to contour this plate, seminal plate, or a 3.5 DCP to 120 degree double angle blade plate, or you can at times also contour 4.5 DCP here. If you excise a wedge of 20 degree, place the fracture at right angle to the body weight forces, the fracture heals. And so is true with this coxa vara, this pseudarthrosis also heals. So here the wedge is excised and a near normal neck shaft angle is given. Functional X-ray should preferably be taken in full adduction and full abduction. Full adduction is a good indication of valgus intertrochanteric osteotomy. So now this technique has been decorated in Campbell's. Complete details can be read. You can decide the point of entry. You can decide the implant. You can decide what type of wedge you are going to excised, you can lateralize the distal fragment and can do a good fixation, osteosynthesis and valgization. So this is an adductor fracture neck of femur. So this hemitor plate is converted into double angle blade plate and the fracture is healed in 20 weeks. You have to supplement this fixation with the hip spica as this implant is weak. Coxa vara 70 degree. So midline angle, Watson-Jones type. This is fascial lata. Anterior 2/3 of the vastus latalis sleeve. You take it anteriorly. This is the K-wire at the upper border of the lesser trochanter. K2 wire is in the direction where you are going to put your chisel, that is seated in the inferior part of the head of the femur, and that is the wedge 50 degree, because 70 degree has to be converted into 120, so we excise a wedge of 50 degree. Conditions bilateral in this patient. So that is the 50 degree, 60 plus 50, so this guide has to be at 110 degree because we are going to use a 120 degree blade plate. So this is the wires perioperative. So this is the distal osteotomy cut. Here is the proximal osteotomy cut. This is the chisel, pediatric chisel I should say, AO type. That is the wedge which is excised. You can also excise a half wedge and place it medially. So angle between the plate and the shaft of the femur should be equal to the angle of the wedge. Otherwise there will be error. So this is the wedge has been excised. Now you abduct the distal fragment and the procedure is over. If you are able to place it at right angle to body weight forces R, the pseudoarthrosis will heal. That is what we achieved, 70 to 120. This is wound closure. This is after 5 years. So this is the first case which I did in 1990, healing 20 weeks. This is after 12 years. This is after 24 years. Mild scoliosis is there in the joint. The function is excellent. When she was 10 years old, when she was studying for her master's degree, now she is married, has 5-year daughter, hip is well. So excellent procedure to correct painful hip disorders. Near normal biomechanics can be restored to achieve stability. Correct shortening can bring about healing of the neglected